Right, so I want to thank the organizers for inviting me here to come and talk about some of our recent results. And I want to apologize also for not being here at the conference more. There have been a number of things that have really been derailing me being here. So this is my son. His name is Dante. This is right before he begins his calculus homework. And he's 20 months old. And this is my daughter, Amalia, who is 8 weeks old. So we are sleep deprived at home, and so I apologize, but I hope that you'll excuse me at this point in time. So just to give you a little bit of what my background is, I am a clinical cardiologist. I still see patients both in an intensive care unit at the West Roxbury VA and at the step-down unit at Mass General Hospital. And my interest has been in the etiology of cardiovascular disease and in trying to develop methods that will help us take care of patients who have a variety of different cardiovascular disorders. My research background is in biophysics. So we do a lot of things in my group, and I started my faculty career working a lot in the field of statistical thermodynamics, looking at biophysical types sort of things, and looking at proteins that are involved in different sorts of disorders. But I had the privilege of interacting with a number of very talented colleagues, John Guttag, Zishan Saeed, Jenna Weens, Professor Jenna Weens being one of them, who taught me that the role that machine learning and computation can play in making inferences, clinically useful inferences from physiologic data. So in the last 10 years, my group has sort of gone away a little bit from this very that I like to think of sort of sophisticated methods in statistical thermodynamics to another set of very sophisticated methods involved at doing something called risk stratification for patients who have a certain type of cardiovascular disorder called acute coronary syndromes. And this is what I'm going to focus on today. I think in order to make the subsequent discussion the most informative, I need to just talk a little bit about acute coronary syndromes and a little bit about the type of data that we use to make these inferences. So what is an acute coronary syndrome? It's a class of disorders characterized by sudden narrowing or occlusion of a coronary vessel, typically arising from something like plaque rupture or erosions. So the clinical description is somebody's walking down the street, all of a sudden they have lots of chest discomfort, they fall to the ground, and they're dead. And you hear of this happening every now and then with particular celebrities and even family members. If you were to take a look, what did I do? If you were to take a look at an individual who presented with an acute coronary syndrome, so here we have a relatively young gentleman who has the presenting symptoms of angina, which means chest pain. He comes into their physician. If the physician could cut open this person's chest and look at their heart, this is what it would look like. So this is a blood vessel which supplies blood to a region of the heart, and this blood vessel should be patent, be completely patent, but at some point in time there is a blockage that suddenly develops within that vessel that denies an area of the heart blood, and consequently that vessel dies. If I were to take a bigger snapshot of this particular vessel in cross-section, it would look like this. Here's a big blood clot, which now takes up a lot of the lumen of the vessel, a lot of the space of the vessel. Prior, the vessel was sort of this wide, and blood could traverse the vessel itself, blood going into the screen. And then at some point in time, something sudden happens. We don't have to talk about the pathophysiology there, but a clot builds up, and whereas the region of the vessel that could accommodate blood was this wide, now it's sort of a lot smaller. And this sudden change in the lumen of the vessel is what leads to what we call ischemia and death. So that's the pathophysiology of it. But the patient, when he or she comes into the physician, you don't have these data available. You don't really have the size of the vessel. You have to do invasive procedure to do it. What you have is what you get from looking at the patient and the measurements that you make from the patient. You can measure their blood pressure, their heart rate. You can take the electrocardiogram, look at their oxygen levels. And it's using those data very early on that one has to make a determination as to what's going to happen to the patient and the patient's disposition. So this leads to a number of problems. So there are central problems in the treatment of patients with this very serious disorder, acute coronary syndrome. The first is Can I identify patients at high risk of an adverse outcome before the outcome is realized? Patient comes in, I just have their physiologic data, I have what he or she tells me. Do I know this? Is this somebody that's going to die within the next 24 hours, during the hospital stay? Are they going to live? That's an important thing. Somebody who I think is going to die, I'm going to be very much more aggressive. I'm going to possibly recommend some invasive procedures that entail their own risk. And it's only worthwhile doing it if the risk of death is greater than the risk of the procedure. Another question is, it's just not enough to know if the patient is at high risk. If a patient is really at high risk, what interventions can I use to lower his or her risk? These are the two core problems in cardiovascular medicine, and there's similar variants of these problems, I should say, that are relevant in all aspects of medicine. So first, I'm going to want to focus on this first one. Can I identify patients at high risk of an adverse outcome? And if you look at prior work here, there's been a lot of work. I'm not the first person to say this notion of risk stratification, identifying patients at high risk of adverse outcomes like cardiovascular death, been around for a while. And there are a whole slew of what's called cardiac biomarkers that are used to determine a patient's risk. So a cardiac biomarker are often used to quantify a patient's risk, and biomarkers serve as risk metrics. So if you look at the definition of a biomarker, it's sort of a distinct biochemical, genetic, or molecular characteristic or substance that's an indicator of a particular biological condition or process. Some examples. So there's something called cardiac troponin I. You measure this. It's something that is produced in the blood when heart muscle dies. And the higher the level, the greater the risk of death within some number of days after presentation. There are other markers that you can measure in the blood. Some of them have been very popular, called C-reactive protein. All of these things are known, and they're biochemical. The amount of heart muscle that dies, the greater the amount, the greater these values, and subsequently the higher the patient's risk of an adverse outcome. But indicators of risks don't have to be biochemical. When you first see the patient, the things that you get automatically, very quickly, are their heart rate, their blood pressure, their vital signs, and electrocardiogram typically can be taken within seconds or minutes at most of their presentation. And certain abnormalities in the electrocardiogram, this is a particular abnormality. It's not really important what it is now. It's just something that can be identified by eye looking at the electrocardiogram. When it's abnormal, this one is very abnormal, 2 millimeters of ST segment depression, your survival goes down by quite a bit relative to those who don't have this finding on presentation. So, this is evidence to say that there are some predictors without having to, measure something in someone's blood that have prognostic value. So in the first part of this talk, and some of this is sort of historical, I want to talk about building computational biomarkers from the surface ECG. It's a very simple sort of learning problem, and we'll build on from this to go to sort of some more complex models that I think are more interest. Now, my understanding is that the audience here is very, very varied. There may be some people here with clinical background and some people here with a strictly machine learning background. So for the clinicians, I'm going to keep the words monosyllabic. It's a joke. I'm a clinician myself. And try to make this as transparent as possible. So the electrocardiogram. The electrocardiogram is a measurement of electrical activity through the heart. This is a sample electrocardiogram taken from a patient who's normal. A normal electrocardiogram tells you a lot of things. It tells you that the heart muscle the conduction system, at least, to the heart is normal. And the interaction between the heart and the brain are normal because everyone's got a certain heart rate. The heart rate is not constant. It changes with time. If you record the electrocardiogram over a period of time, there'll be changes in the heart rate that you can measure from the electrocardiogram. So a normal electrocardiogram, the heart's normal, its interaction with the rest of the nervous system is normal. So we like to say that there are two types of things that we can deduce from a normal electrocardiogram or from any electrocardiogram: the health of the endogenous factors. So that's the myocardium and the conduction system, things that are endogenous or intrinsic to the heart itself. And then exogenous factors, things that involve the interaction of the heart with something else, the nervous system. So just speaking about one of those things, looking at the exogenous factors itself, people have said that these things have prognostic value in and of themselves. And how is that done? There's something probably many people here have been familiar with called heart rate variability. You measure an electrocardiogram over some period of time, and you make it a time series from those data. And from that, you can do some processing to get some indicators that tell you whether the patient is well or not. And how does heart rate variability work? So Each of these corresponds to a beat. You could think of each of these peaks as one beat of the heart. So the time difference when this beat occurs and this beat occurs is the time it takes for one beat. So here, I'm going to refer to this as the RR interval. This is the heart rate, the instantaneous heart rate for one beat. I can do this for the next beat and so on. And I can do this for a long time series and get a heart rate time series. And from the heart rate time series, I can get some summary statistics. And these are all referred to as heart rate variability statistics, and they're indicators of risk. I said, you're sitting at home and you're watching a Red Sox game, your heart rate goes up depending on what they're doing and whether they're winning or losing, and that's a normal consequence. It's a normal thing. You go up the stairs, your heart rate goes up because you need to increase your cardiac output. You're doing some physical activity. So the heart rate should vary. So these heart rate variability metrics, let's say if I looked at the standard deviation, tells you that it's normal if the standard deviation is non-zero, because it should change as you go about a normal day's activity. And it tells you that the interaction between the brain and the heart is normal, referred to as these exogenous factors. Now, there are some problems with looking at these very simple computational metrics of the electrocardiogram. So for example, these are data taken from 2 patients after an acute coronary syndrome. The patient on the left died within 90 days of the index event. An index event is what they presented with. This person lived. And the heart rate variability metrics for these 2 tracings are the same. So there's not everything that one can garner just from looking at variability in the heart rate. So years ago, I think over 10 years ago, our initial approach to this was computationally, what can you do? Just from the electrocardiogram, can you take additional information that may be very difficult to see by the eye? Well, you get some clues when you look at this. So this is called a P wave, and this is called a QRS. They're all part of the same beat. There's some distance here, which seems to be much narrower here. There's some slope, downsloping here, which seems more prominent than it is here. So there's some very subtle effects that are different between these patients that may have prognostic value. So we had a hypothesis that there are some variability in the sequence with beat-to-beat variability in the actual shapes of the signals. That's a much more sophisticated measure than just looking at the timing of each of the beats, and that those data had prognostic importance. So the approach early on was to develop some metrics that quantify subtle beat-to-beat variability that you can't really see with the naked eye, and that if there was a lot of variability, the underlying system was unstable, and that would impart high risk. So if you go back now and take a look at the same time series, and now instead of talking about the timing of the beats, and I'm talking about how do the shapes of the beats differ. So for example, instead of looking at the timing when this beat occurred, and looking at the timing between them, I can take a look at this beat and compare them and get some sort of distance metric that quantifies how different these beats are. You can just sort of compare the samples together at the 0th order level of approximation. And I could do this subsequently for each of the other beats. And just like I had a time series previously for the heart rate, I could have what's called a morphologic distance time series. And I could summarize the variability here, just like I did for the time series data, to get metrics that may be important. So the morphologic distance time series quantifies differences in the shape of consecutive beats. And this is done very simply, just as an aside, using a dynamic time warping algorithm that allows you to create an alignment that minimizes the distance between these 2 beats. And the value of that distance is what we use as a morphologic distance. And the alignment is important in this case because different regions of the beat correspond to different types of physiologic activity, and you want to make sure that they're aligned and being comparing the same types of physiologic activity when you're actually computing these distances. So the overall approach is we have an ECG, we pre-process it to remove artifacts and abnormal beats. We compute the morphologic distance time series. Then we summarize the variability using a variety of different metrics, and we get a morphologic variability measure. So there's really no learning I've talked about here. This is all sort of just taking the raw signal, but it's a little bit more complicated than that, in the sense that when you look at the heart rate variability and you take the instantaneous rate time series, most of the successful metrics have been done in the frequency domain. So you have a time series of the instantaneous heart rate, you transform that to the frequency domain, and there's one frequency band that has prognostic value that has been learned with time. So if we're going to follow the same sort of approach, because HRV metrics, at least the ones that have been most successful, at least for the type of patients that we look at, in the frequency domain that have predictive power, they calculate the power spectrum for a particular frequency band. So to do the same procedure, we have to learn what the frequency band is. So a very simple problem. So we want to find the optimal diagnostic frequency band. It's learning from a single parameter. We have a small data set consisting of about, at least in the cardiovascular world, this is a small data set, of 861 patients who all presented with an acute coronary syndrome. We can compute the morphologic distance for all of them, look at all possible frequency bands in a heat map, and look at which one has the most predictive power as determined by the area under the curve. So we've learned our one parameter. We have an additional data set now that has about over 4,000 patients, again, all who presented with acute coronary syndrome, and we can apply what we've learned to the new data set. And this is a Kaplan-Meier curve where the red denotes the death rate in those patients who are at high risk as denoted by their morphologic variability value, again, which was learned on the previous set of patients, and those patients that are at low risk. And the hazard ratio is greater than 3 at about 90 days after or so. I think actually, I'm not quite sure what the time is here, about 12 weeks or so after the index event. So there's significant importance here, I think, at least prognostically for these patients. But this is not enough because we have this morphologic variability metric that we think is useful by looking at these particular data. But does it really tell us anything over what we already know? So for example, if the morphologic variability metric was gave high values to everyone who was 90 years old, right? That wouldn't be very informative because you would say that if you're 90, your risk of living well, given the current administration, I guess it is a risk. Your probability of dying in the next 10 years. My wife tells me never to make political jokes when I'm out here, but this is Boston, so I guess it's okay. So we want to be able to compare and see, does this tell us anything over and above what we already know, right? So we can do this in a multivariate model. So we can put many different variables into the model that we know are correlated or associated with an increased risk of cardiovascular death and see what we learn if we account for all of these other variables. So in this model, we created a Cox proportional hazards model, which has different types of variables. This is a type of metric derived from the heart rate time series called deceleration capacity, heart rate variability, morphologic variability, which is what we've created. The TIMI risk score is a standard score that's used by clinicians all over the country to sort of identify patients at high risk of cardiovascular death and other adverse outcomes. Body mass index and the creatinine clearance is a measure of your renal function. And if you look at the things that remain statistically significant in a multivariate model, the morphologic variability is one of the metrics that actually is still significant after including all of these other things that we know impart significant risk. But that's not enough. Let's say we talked about a lot of these metrics, or most of them, are ones that you get from looking at the surface electrocardiogram. They're blood values that you also can measure from a patient that tell you a lot about that patient's risk. So if you know the blood value that tells you that the patient, of a particular marker, that tells you that the patient is high risk, do you learn anything more by doing these calculations on the electrocardiogram? So one is a brain natriuretic peptide, BNP. High levels are associated with a higher risk of death, both in the short term and in the long term, of patients with cardiovascular disease, in particular patients who present with an acute coronary syndrome. And if you look at the morphologic variability value, whether it's low and it puts you in a low risk, or whether it puts you in a high-risk class, these rates are very high relative by the standards of care in cardiovascular medicine. This is the death rate after 1 year after presenting with an acute coronary syndrome. 4.8% is quite high. You could argue that, once you know that this value is high, the morphologic variability really isn't useful, right? If somebody tells you you have a blood marker that says that you're at high risk of death, it really doesn't matter what your ECG says. It's going to be hard-pressed, and it should be hard-pressed to find any clinician that would treat you differently and ignore this piece of data. The important information is what happens if the test tells you that you are low risk, right? Should the clinician let you go? Well, if your morphologic variability value signifies that you are at high risk, then your risk of dying is approximately almost 5-fold higher than if it were low. So even those patients who you would say are low risk based on this particular blood value, the morphologic variability in this cohort still holds prognostic value. Similar things can be said from other tests that are more time-consuming, looking at the left ventricular ejection fraction. Just like before when I talked about the BNP being high, it's a marker of increased risk. Left ventricular ejection fraction being low is also a marker of increased risk. These patients have bad outcomes. But when it is not low, above the threshold that most clinicians will look at, still the morphologic variability being high imparts a higher risk of death. So I think that these data argue that at least this very simple problem, looking at the electrocardiogram with a physiologically based hypothesis, allows you to process it in a way that gives you prognostic information. But can we do better? So morphologic variability uses data from pre-specified frequency bands. Now, so it doesn't look at the entire ECG. Can we use information from the ECG time series more directly? And can we use less information? All of the data that I showed you before required about 10 hours at minimum of continuous ECG data, which is routinely acquired parenthetically for patients who come into the hospital admitted with an acute coronary syndrome. But it's still a fair amount of data. Do you really need all of those data to make the same thing? And do you really need to look in the frequency domain and do all of this other sorts of stuff? Can you directly use the raw signal without this sort of pre-processing or as much pre-processing? You get some insights in some of the data that I showed you previously. When you look at the ST segment, which is, again, a region of the ECG, and you look at it by eye, there's quite a bit of prognostic value when the ST segment is depressed. So there may be regions of the ECG that we can focus on in our analysis and for building our models where we can have, that we can get clinically useful models. So let's try, again, to do some feature construction that we're going to use for maybe some more sophisticated models from the ECG time series. So here, this is an ST segment. Each of here, so this is this region right here between this tall spike and this other wave is called the ST segment. And that's when I said in the previous slides that the ST segment is depressed. This is what clinicians look at. So let's say I took a look at the time series of all of the ST segments. My hypothesis here is different, that I can sort of just look at regions of the ECG, regions of each beat that I think are important. I can do some feature construction, some feature engineering from those data that give me powerful models. So here, let's say I'm taking a sample, or if I just sort of isolated these two beats, let's say. And here, this is the ST segment here. Again, corresponds to this region here. This is the ST segment of another beat. So there is some previous literature that takes a look at the actual samples corresponding to the ST segment and expands this in some sort of basis functions. These are Legendre polynomials that I can use to expand these curves. And there are different types, and there are many different types of things that you can use to expand. This is just sort of samples representing a particular curve. Type of function isn't horribly important. But we can expand this into, let's say, 16 different coefficients. And let's just take a look at the first two for a minute. The first corresponds to sort of the height of the ST segment, the average value. And the second coefficient corresponds to the slope. So here, this is the slope, and this is the ST segment, the average value. And here, this slopes down, so the average value is lower, and the slope is as such. I can model each of these ST segments by a vector corresponding to what those coefficients are. And I can choose how many coefficients I'm going to use. And for this work that goes forward, I'm just going to use these two coefficients. The hypothesis here, the clinicians, they look at sort of how the ST segment is raised or depressed and the slope, and this quantifies those data, and I can put them into a model. So let's say I'm going to use a very simple model, a logistic regression model, because I'm interested in determining how powerful are these features, just the features themselves, with a simple method for discriminating patient risk. So if I look at this and I apply this to an independent cohort of patients, about 4,000 patients or so, it's learned on a small, actually, so these results come from bootstrapping. We have about 4,000 or 5,000 patients. We bootstrap this about 1,000 times or so to get the data that I'm presenting here. So this is the AUC. These are AUCs on the y-axis associated with the TIMI risk score. Now, the TIMI risk score is sort of what I mentioned previously. It's what clinicians use to make determinations about their patients, their risk and their determination. This is a logistic regression model that comes straight from the patient's history, the cardiac risk factors, their age, their gender, and such. So the TIMI risk score actually does pretty poorly. it gets an AUC about 0.67. And this is held true in the literature. If you look, there are published studies with the TIMI risk score that have been applied to different data sets of patients post-MI and with different types of cardiovascular disease, and the AUC never really gets much more than that. Patient history by itself gets you a better model. Now, if I combine the history with some of these ECG metrics, and I do logistic regression models of those, they do better. So it's not surprising. You have the history and you combine it with other data that you think are useful. If I combine the history in a logistic regression model, the morphologic variability metric that I talked about, you do better. And if I take the history and I just look at the presence by eye, but the clinician tells me whether he or she checks off there's ST segment changes on admission or not, and I put that in with the history in a logistic regression model, I do even better. So this says that these data, at least previously, looking at the history, the morphologic variability, and the ST segment, and actually there's a piece of this that that is cut off from this slide. It's the history with the metrics that I actually talked about previously is even higher in the AUC. So that's an error in this slide. The upshot here, and the point I'm trying to make, is that the actual metrics for the ST segment themselves just have prognostic value. If you compare them with using the same logistic regression model to other types of features that you know are informative, then you can do something that is useful. So can we do even better with some more sophisticated models? The previous models that I talked about that just used the ST segment, it really just you had a sequence of these coefficients and you just took an average. So you lost the time series information from the data. So can I actually use the time series itself rather than just the aggregate value, just the average of all of these values for some set of beats in a particular model? And this is where our neural network comes in, because neural networks are good formalism, at least we found, for actually specifically including the time series information. So for each beat, again, we model each ST segment with two coefficients from this Legendre expansion. And then we have a recurrent neural network that takes in two inputs, one for both the corresponding to the average value of the ST segment and one corresponding to the slope. And we train in a supervised learning manner, train a recurrent neural network to predict those who are at risk of death 1 year after they present with an acute coronary syndrome. So we know that we get added information not just from the ECG itself, but from the patient history. So we've combined two arms in a final model. Here we have the recurrent neural network that we've trained separately. And we take the output of the recurrent neural network and we use a logistic regression model just based on the history. And we combine that together using a standard sigmoidal output. It's sort of essentially just doing logistic regression on these two outputs to get our final output. So the model includes both the time series data from the ECG and the history information. So one of the things to note, as opposed to a deep learning that has thousands and hundreds of thousands of parameters and one needs lots of data to be able to do this, we don't have hundreds of thousands of patients to be able to train this. So one of the constraints in doing this is that we wanted to make sure the model itself was relatively low complexity as measured by the number of free parameters. So the final model in the recurrent has only 218 free parameters relative to about 4,000 data points, 4,000 patients that we have. And the model is trained in terms of the beats, only the first 50 beats in the ECG training, in the ECG tracing, the first 50 usable beats. There's a provisor here that I'll come back to later. So a relatively small amount of data, certainly much less than the 24 or 48 hours of data that we have for each patient. And these are the additional features, the history features that go into this aspect of the model. So now, if you look at the results of just this artificial neural network, which I'm calling this conglomerate model that includes a recurrent neural network, and this other model built from logistic regression, just weights based on the patient features, has an AUC of about 0.74, which is significantly better than all of these. And we've done sort of paired t-tests for all of these comparisons to say that this artificial neural network outperforms the rest. When I talked previously about morphologic variability, I mentioned that it was important to also look at a multivariate model because you want to know if your new model tells you more than what you already know. You know some things have high predictive value. And you wouldn't be doing much if the artificial neural network is just predicting, again, in an extreme case, patients who are over 90 years old. So if you put this into a multivariate model where you control for the metrics that I talked about last time, the brain natriuretic peptide, a known indicator of increased risk, the left ventricular ejection fraction, and the TIMI risk score, and you look at sort of the artificial neural network and this model that uses just the history and the average of all of this denotes here, and the average of all of the ST segments. So this just does not include the time series data. This is the average of all of the Legendre coefficients from the 50 beats. It outperforms it, and this is statistically significant, different in the difference here. Whereas before I was talking about the AUC, here this is the hazard ratio. So the hazard ratio tells you the rate of death in patients that are positive versus the rate of death in patients who are negative for the marker you're interested in. And so if you are positive via this artificial network, you're 3.7 times more likely to die in a subsequent year than if you're negative. And if you just looked at the univariate, so we're talking about 1 year risk of death. This is a univariate analysis, so this is not controlled for all of these other metrics. It's harder to control for all of these just because the data are smaller. But if it's still predictive at 60 days, it tells you you have an increased risk of death at 60 days, 30 days, and even 14 days after you're positive. If you're positive for this, you're more than 5 times more likely to die in a subsequent year. So it seems as if not only can we say something about a year out, but it's close to 14 days out. And moreover, if we looked at specific patient subgroups, is it predictive? So if you looked at the age, patients who are greater than 65, patients who are less than 65, this is the hazard ratio, each point here, and this is a 95% confidence interval. When a 95% confidence interval does not intersect 1, it's statistically significant. And in all of these subgroups, whether you're male, female, whether you have high blood pressure or not, in most of them, whether you present with ST segment depression or not, whether the physician can say you have ECG changes or not, it doesn't matter. It's still the hazard ratio is still predictive. Now, all of these data were generated with bootstrapping. So as one final test, we have one independent holdout cohort that we have not used at all in any of the model design or testing. And if we apply the model in that sense to this cohort, this is the associated Kaplan-Meier curve, again, where we have the death rate for those that the artificial neural network identifies as being high risk, and for those the artificial network identifies as being low risk. The significant divergence between the two. So between the bootstrapping results and independent cohort, I think we actually are onto something with this particular model. So the computational biomarkers, I think, just as to finish up this part, the biomarkers themselves don't have to be genetic. They don't have to be drawn from the blood. There are some powerful biomarkers that can complement those traditional biomarkers that clinicians use arising from blood samples. So we talked about this. Can I identify patients at high risk? But then the question is, if I know a patient is high risk, what interventions can I do? And this sort of gets a little bit to what was talked about previously in doing some reinforcement learning, something that we've just started to do, and these are some very preliminary results. So I think certainly those who work in this area are familiar with Q-learning, which is specifically what I'm going to be talking about briefly here. But just to get the terminology correct and to frame the problem correctly. So suppose we're interested in a given patient. We know his or her risk profile. The risk profile has been quantified by, let's say, using the TIMI risk score, maybe the artificial neural network, or some complex model that involves lots of disparate pieces of data to get an accurate prediction. And the question is, should this particular patient with a given risk profile be given this particular therapy? So if we call T the therapy, and we're interested in determining whether a patient should get it or not, we have this risk profile, which can be some collection of variables that are prognostic indicators. And for the subsequent discussion, I'm going to assume I'm just going to be working with the artificial neural network, which again builds a risk metric from many different types of data. And then Y is the output. So it's the expected outcome of a patient who has a particular risk profile R and is given a certain treatment. So we want to get a decision rule specifically that for a given risk profile assigns a treatment for a given patient. That's really all that this is, right? Risk profile treatment, we want to get our decision rule. And it's very simple. In oncology, this is a method that's used in multiple stage settings. So at a particular time, one wants to make a decision, you acquire some more information, and then you make a decision about what should be done at that time T plus delta T, after another time delta T, and so forth. I'm going to use this just in its most simple way in a single stage setting. So in Q-learning, specifically looks at the expectation value of the outcome right? And models it by some, usually a linear function, or it doesn't have to be a linear function, but most of the things in the literature tend to be linear functions. And then the optimal treatment strategy just maximizes, it's an argument that maximizes is the Q function, maximizes the expectation value. So the formalism is very simple. You don't, and in a single state setting, very straightforward to do. So we have 4,000 patients to test this. These 4,000 patients were randomized to receive a medication which is currently used quite frequently in a cardiovascular setting called ranolazine. The study was called Merlin, and the upshot of the study is you give ranolazine to all comers, and you randomize it, has no effect on mortality. Helps somewhat with symptoms, but it doesn't affect on mortality at all. So we said, okay, well, let's try Q-learning with this Merlin data set on all of the patients and see what we find. And you find an optimal treatment strategy because, that's what the algorithm does, gives an optimal treatment strategy. But to see whether the optimal treatment strategy actually does something, you have to apply to an independent set. This is our choice in order to validate this. And you look at those patients who actually followed the treatment strategy retrospectively and those who didn't, and see if there's a difference in the death rate between the two. And there isn't any, right? Shouldn't be a surprise, right? Because the study, when you randomized, it did not find a difference in the death rate between ranolazine between those who received it and those who didn't. But the interesting thing is, if you use your artificial neural network to identify high-risk patients, and then you say, I'm going to apply, can I get a treatment strategy for high-risk patients that make a difference? So if you look at those patients in an independent holdout set that follow the treatment strategy, their death rate is about 12, and the death rate a year after presenting with acute coronary is about 14. So we think, at least in this particular case, and it's just an example of mechanisms that you can use when you find patients that are very high risk, as identified by methods like what we've talked about in the first half, and then you can apply and then devise a treatment study that's specific for those high-risk patients. Can you make a difference? And there have been studies. So the question is, how does this compare to what is currently known? And there really are no studies that have looked at high-risk patients, certainly in the way that we've defined high-risk patients, because it's what comes out from this artificial neural network. But there are other studies based on animals looking at ranolazine that have showed some impact with respect to the risk of ventricular arrhythmias, to suggest that it may be lower in those patients. So this is an ongoing work, but I think it's the type of studies that we're interested in pursuing in the future. So I think the conclusion here, machine learning, I think, provides a powerful mechanism to find treatment decisions that are optimized for a given patient's level of risk, a central question in the care of patients with cardiovascular disease. And now to the people who did the work. So a very talented PhD student in my group, Paul Daniel Myers. It's very hard when you've been up most of the night holding it. Did all of the work with the neural networks. The morphologic variability, again, my very talented collaborators, Professor Jishan Saeed, who is now at Michigan, Professor John Guttag. Yin Liu also was a very talented student in my group who has since graduated. We get our clinical data from the thrombolysis in myocardial infarction study group, which is based out of the Brigham Women's Hospital, and our collaborator there is Dr. Ben Sirka. Okay, thank you.
We can take a couple questions.
So you found some difference that your recurrent neural network actually helps model because of some temporal information, waveforms. But I also recall that you were using only the first 50 heartbeats for each patient. So I wonder how much temporal information can we extract from 50 beats versus a time of like a couple of weeks or so?
It's a great question. It's a great question. And I should add a proviso, which I actually did not mention until I should say now. So we have to identify the ST segment in each beat. And we do that in an automated fashion using some PhysioNet tools and some other things that have been published. So we have a long data stream. We apply tools to identify the ST segment. Not every beat has an ST segment. So the first 50 beats actually corresponds to about 45 minutes of data. Still a relatively short period of time, but we need about 45 minutes to get 50 labeled beats. Now, nevertheless, I think one of the things is how much data do you actually need to make a determination about the patient? This curve that I showed you in terms of the SD segment depression, I don't know if you remember that when physicians identify that early on, that the risk of death is much higher, even a year out, that comes from about 10 seconds worth of data. That's a 12-lead electrocardiogram. I mean, again, it's more than one lead. You get 12 separate different tracings, but the total time is pretty short. So I think there is something to say that whatever state the patient is when he or she arrives is what determines their outcome. And there may be a complex panoply of factors, of biochemical and history and otherwise, that determines that state. But it would argue that you actually may not need that much data soon after presentation.
So when you were analyzing the waveforms, first you look at the RR, the timing, and you look at the spectrum from that. That was basically a Fourier basis. Then for the ST segment, you use the Legendre basis. So you did a different basis that you're mapping to. You're looking for something different. So I'm familiar with Fourier analysis and for frequency, timing kinds of things. What was the motivation by using Legendre, and what other kinds of basis functions might apply for cardiac?
It's a good question. So I think, a lot of the insights that come from my group are driven clinically. So we look at the ST segment. As a clinician, I could say, okay, well, when I look at the ST segment, that region of the electrocardiogram, what am I looking for that's important? Well, it's the height of it, whether it's depressed or elevated, and its slope. And there may be some secondary things, the curvature and such that I look at. And the thing that was nice about the Legendre expansion is that those terms correspond to what I think of clinically as being important. The first term is the average value, which corresponds to sort of the height. The second term is the slope. The third term is the curvature, and then these higher order terms, that might not be as meaningful given the sampling rate of the signal. But nevertheless, so that was a rationale for choosing something like that. It's not to say that that's the only expansion that we can use. It just sort of fit our clinical, some domain-specific knowledge that we had. Oh, hey, David.
You're doing this pull-out stacking stack, and you were testing the neural approach. Data was drawn from a slightly different.
So the data were different distributions. So they were different trials with very similar inclusion criteria.
Often you find a generalization of more complex models like quite as good when you go out of sample as so much.
Yes.
Did you look at that at all?
So I think the things that one can do to try to mitigate that is to look at the properties of the both data sets. And the inclusion criteria for both Merlin and Disperse 2 were quite stringent because they both were looking at patients post-acute coronary syndrome. They were designed specifically to look at the same type of patients. And at least we cannot find any statistically significant difference, at least in the parameters or the features that we think are important. And for these things, the more data one has, the better. And we still have. Oh. Well, so the more, right, so certainly if one has data that are very different from one another, then it's bad. My statement is the more data that one has that from the same type of patients that one is interested in, I think the better. And these two particular data sets were specifically chosen because it was the same disease. It was different treatments, but on the same patient state that was of interest.
All right, one last question.
So there are models that have very few parameters that can model many aspects of the cardiovascular system. And the reason that they have few parameters is that there's a physiologic basis for them, so that one can rely on the physiology to sort of get the connections and the underlying structure of the model. And you can minimize the number of parameters that are again. And I think those models are good for certain types of questions. If we really understood the physiology that leads to adverse outcomes, I think those things would be useful. The issue is that, cardiovascular disease is a mixture of many. I mean, we measure the outcome of cardiovascular death, but it's really many sorts of types of different disorders that we really don't know. So my sense is that approaches that are sort of relatively naive and don't make those types of hardwired physiologic assumptions at the outset are going to be more useful for these realistic type of clinical problems.
All right, let's thank Colin again.
Okay, thank you.